Another term that I incorrectly use interchangeably is the term air sac. Or I'll say an alveolar air sac. Technically, an alveolar air sac is one of these structures, all right, where we have a bronchiole and then all the air sacs, alveoli associated with it. I never use the word air sac in that context, okay? So I'm trying to say alveoli, but if on a lab quiz or those online quizzes or whatever I talk about an air sac, I'm talking about just one of these. So an alveolus, okay? So let's look at the structure of that. As I said, it's the smallest of our airway components, and it definitely is the end zone, the end destination of oxygen when we're talking about gas exchange, or the point at which the air picks up carbon dioxide that it's delivering from the body. So if we draw an alveolus, all right, it is formed of simple squamous epithelia, just like we've been talking about. And this is identified as type 1 alveolar cell. It's just our normal simple squamous epithelium. Okay. In between, or inserted amongst the simple squamous epithelial cells, type 1, are type 2, which are not involved in gas exchange, but are involved in the synthesis and secretion of a lipid material known as surfactant. And so this is identified as a type 2, or alveolar cell type 2. I don't care whether you put the type 1 or type 2 in the front or the end of the term. And an older name for it is a septal cell. Okay. It has tiny little lipid droplets in it because it uses lipid as its precursor in synthesizing molecules known as surfactant. So these type 2 cells synthesize and secrete surfactant. This creates an oily film on the surface of this alveoli. Anybody know its purpose?
Lubrication. So like
Not so much lubrication. They're kind of close, but not quite. Let me illustrate for you. Here's another one over here. So I grabbed a little baggie on my way in from the lab techs. All right. So this is the simple squamous epithelia of my alveolus. And remember, in the fetus, the lungs are filled with fluid to allow the spacing in the alveoli so that they don't grow solid. And so when, I'm not sure if this is going to work, if it's a different kind of coating, but anyway, so it's a surfactant cell. So, so the fluid starts to be, as the serous fluid that's filling the alveoli starts to become reabsorbed by the body, starting about 2.5 to 3.5 weeks prior to birth. Because obviously you don't want an air sac full of fluid when the baby takes its first breath. As the baby is delivered through the vagina, more squeezing that's passed through helps to move that fluid into the throat, all right, where it can swallow it or spit it out. But it's still coated with this serous watery fluid, right? And that creates surface tension between the surfaces. So and this one doesn't unfortunately have it, but if you were to take a glass of water, you probably learned about surface tension in Bio 430, and you put your finger on the surface of the water molecules on your hand versus water molecules on the surface of the water are going to be attracted and pull up as you start to lift your finger from the surface until finding gravity breaks those. We talked about hydrogen bonds. All right, so hydrogen bonds are formed between hydrogen and oxygen, or hydrogen and nitrogen, some electron-hungry molecule. So if we have here's one surface of the alveolar air sac, and it's got hydrogen and oxygen. The polarity, the need that oxygen has to stabilize its electron valence attracts the hydrogen's single electron. That makes it attractive to the negative polarity of the oxygen on another molecule, and that creates a positive-negative attraction between the hydrogen and the oxygen of two separate water molecules. And this is a hydrogen bond, all right? It's the weakest of the bonds, but it's sufficient to cause these airways to be attached to each other when that infant is born. And all of those hydrogen bonds have to be broken when the baby takes its first breath. That takes a lot of energy. An adult lung has the alveolar surface area of about the size of a tennis court. So even if you take 10% of that for an infant, it's going to be a lot of hydrogen molecules, hydrogen bonds that have to be broken. So the baby breaks those bonds, it lets out a wail, and then it breathes it out, and the alveoli collapse and stick together again. And the next time it has to take a breath, it has to break all those bonds again. This is what happens in newborns that are born too early, that haven't produced sufficient surfactant. They use up a lot of energy trying to break those bonds every time they take a breath, and that is known as respiratory distress syndrome, RDS. So it is prevalent in preemies because they're not yet secreting sufficient surfactant. And so at first, before technology advanced, they were treated by being given extra oxygen, which is toxic. Remember I told you about my friend who had the patent foramen ovale, how he was blind in one eye? Lots of babies became blind in both eyes, was the usual case, because the oxygen was toxic to the retina, and the capillary arterioles would constrict, and then the neurons wouldn't have any oxygen at all and die. Putting them in a positive pressure incubator, where the pressure, when they breathe, increased air pressure in the incubator helped to push air into the lungs. They didn't have to create quite the negative space around it to create the negative decrease in pressure to contribute to that. And then as technology developed, the aerosol sprays of surfactant were given to the infants after birth to kind of coat the linings, the alveolar air sacs with surfactant. And now they're given precursor drugs as they're still a fetus. So if the doctor determines that this baby is going to be born early, we can't stop it, even if the mom is on bed rest, if they have time, they can go ahead and give the baby the precursors to surfactant to encourage its formation and synthesis prior to the baby's being born. So that, the absence of the presence of surface tension here is a negative as far as the function of the alveoli are concerned. It causes the alveoli to stay collapsed, all right? Before we finish today, we'll talk about another site where it's a positive. It's helpful to breathing. So the surfactant, the type 2 cells are secreting this film, this oily film of surfactant that covers over the surface of the airways. But underneath, moving around under this film, are macrophages. Alveolar macrophages. And these are also known as dust cells. So their purpose is to remove particulate matter. We've got the mucus and the goblet cells all in the airways all the way down that are trying to trap. Only the finest of the particulate matter will make its way that far down. And so these macrophages will kind of amoeboid-like move around on the surface. So we normally find them in loose connective tissue. We find them in the blood, and the spleen, and the liver. But we find them here on the surface a very unusual place for them. The only reason they don't dry out is because they are under that serous surfactant fluid. Much of the material they pick up at this time, there could be viruses and bacteria. It's been found that individuals who have a heart attack and then have pneumonia subsequently to that are at increased risk for a second heart attack or even valve damage, because these macrophages will migrate back into the blood and end up in the heart and can cause damage to the heart. So here's a couple of images of the macrophages are on the surface, or here if you see little white circles, those are the lipid droplets of the type 2 cells. Here's a diagram showing the macrophage. This would be the lipid, lots of the fatty acids and material under that film. And here's a type 2 cell making the lipid material. And that's a type 2 cell along the wall. The upper nucleus would be of a type 1. And there's some cells in the middle that would be the alveolar macrophages. So here we have, this is very similar to our model. We have the bronchiole. This is not a bronchus because it doesn't have any cartilage, just smooth muscle. Here it is a respiratory bronchiole because it has an alveolus. All right. The vessel traveling with the bronchiole is a pulmonary artery. And then, of course, this is a pulmonary vein carrying away the oxygenated blood back to the lungs. Now, the model we have, similar to this, has those vessels painted the wrong color. Pulmonary artery should be blue and the pulmonary vein should be red. Okay? What would you call that? What would this membrane be right here? What membrane covers the surface of the lung? So we're ready to move next into the pleura. And if it's attached to the lung itself, it would be visceral pleura. All right, so we don't have any fibrous layer, or it's all serous. So it's a simple squamous epithelium attached by loose connective tissue to the surface of the lung. Okay, and we'll diagram that in the next section then. The last thing we're going to look at here is the structure of the lung, and then on Tuesday we'll look at the mechanics of moving air into the lungs. So any questions on this tissue? Oh, one more thing I do want to talk about is respiratory membrane.
I just wanted to make sure I understand. So surfactant is not the equivalent of a lipid material. What's the function of a lipid?
No, it is the oil. It is the lipid.
Okay,
Yeah.
all right.
Okay.
I understood that.
Okay, I was going to draw in the capillary wall, but we can do that when we talk about external respiration. So let's go ahead. Out here we would have the pulmonary capillaries. And gas exchange would be across the, actually there might be a question on the anatomy quiz, so let's just diagram that in now. So at a region where we do not have a nucleus and we don't have an alveolar type 2 cell, we would have the epithelium of a capillary. Remember, the whole purpose of the lungs is gas exchange. There might be another alveolus here. Actually, the nucleus is going to be away from that. And so we call the sandwich created by the two simple squamous epithelia and the connective tissue in between a respiratory membrane. Not a respiratory epithelium, but a respiratory membrane. All right? So let me draw that slightly larger. So it's a sandwich of simple squamous epithelium, our type 1. So this is our type 1 alveolar cell. Simple squamous epithelium. And here's our capillary, simple squamous epithelium. They're both simple squamous. Okay? And what would we have in between? Deep to every epithelium is loose irregular connective tissue, and of course the basement membrane. I'm not going to draw the basement membrane, but that would be part of the sandwich. So loose irregular connective tissue. And so that sandwich, the slices of bread being the simple squamous epithelia, and the filling being the loose connective tissue, would be the respiratory membrane. So on Tuesday, when we talk about gas exchange, this is where that gas exchange is going to occur, all right? So we're going to have oxygen moving from the alveolus into the capillary, and carbon dioxide having a net movement out of the capillary into the alveolus. And so we'll review the factors that affect diffusion. The thickness of the wall, the distance between the two, the solubility of the gas in the membrane, the size of the particles, the concentration gradient. All of those affect the rate of diffusion, and we'll cover that on Tuesday. One of the factors that can increase the distance of diffusion is if we have pneumonia or pulmonary edema and our alveolus becomes liquid filled. Another condition, I was reading, sometime earlier, into the last week actually, about a family, the father, they were celebrating Christmas. The father had been treated successfully for a brain tumor. And then they found out that the drugs that he had been given for his brain tumor had caused increased amounts of connective tissue in his lungs. And he died 3 weeks later of pulmonary fibrosis. In fact, his wife was induced so that she gave birth to their daughter the day before he died, and he was able to hold her. But she said essentially his lungs turned to cement. And with that increased amount of connective tissue, not only could the lungs not expand, but it increased the distance that the gas had to move through to get from the alveolar air sacs to the blood. Okay? So we'll talk about a term next week for compliance. We're going to look at elasticity and its effect a little bit later today with the lungs and the pleural cavity. But compliance refers to the ease with which something stretches. Okay? So elasticity refers more to recoil, whether it's going to come back. So cardiomyopathy, the lungs, the heart will stretch but won't be turned to its original shape if it's oversized. Compliance, let's say I have a really thick rubber band, really wide, stiff. In fact, stiff is a good word for something that has low compliance. It would be difficult for me to stretch it out, fill my lungs with air. Elasticity is its ability to return and decrease in size and push the air out of the lungs. Okay, so compliance. Somebody that has, anybody here doing emphysema for a case study? No? Okay, there was one in the morning. With emphysema, there's a breakdown of the alveolar walls and a loss of surface area, but increases compliance. Without all those walls there, emphysema lungs expand very easily. They don't have much elastic recoil, but they have very low compliance, very high compliance. Someone with pulmonary fibrosis would have low compliance. All right, very stiff lungs, very difficult to expand. Okay, so we'll look at this gas exchange and factors that affect it next week when we do pulmonary ventilation and respiration. Let's finish up by looking at the lungs. So we're looking at the external surface now. We follow the airways and their component conducting aspects deep down into the individual alveoli. And now let's back out and look at the surface of the lungs. So they have a sharp, well, not needle sharp, but a pointed region at the top known as the apex of the lung, which now really is at the top. Remember the apex of the lung was at the bottom? I'm sorry, heart, thank you. And now we come down to the diaphragmatic surface, which is also known as the base. And then each lung has a medial surface where the airways and pulmonary blood vessels exit and enter. And so this is known as the mediastinal surface, where we find the heart. Okay, so there's the right lung. And then the anterior, lateral, and posterior surfaces of the lung take up the impression of the ribs. And so this is known as the costal surfaces, costal for ribs. So if you look at this model, you can see the indentations where the ribs are pressing in on the lungs. So anterior, lateral, and posterior aspects will show those indentations. And those are the costal surfaces, all right? Here would be the apex at the top, the diaphragmatic surface or base, and then the center area here would be the mediastinal surface, which includes the hilum. Just like a lymph node had a hilum where structures exited and entered. Okay? Now, where do you think, point to yourself where you think the apex of your lungs is. Here's my clavicle. Where do you think the apex of the lungs is? All right, when you take a deep breath, it actually goes up to here. It rises above the clavicle into the neck about 1.5 inches. So again, I've never received a letter from anyone saying you saved my life. But if someone was coming at you with a knife, okay, or an ice pick, you don't want to run away going, ah! You want to run away. Push all that air out and your lungs will sink down into your thoracic cavity and you won't get a collapsed lung if you get stabbed in the neck, okay? So one of these days somebody's going to tell me, you saved me from getting a collapsed lung. But I don't know how you're going to do that when that happens.
I think you'll freak the other person out of the never mind. Whatever works.
Okay, this one's a little bit large for the
What if you get a letter from jail telling you told me how to make
I didn't think about that.
Yeah, whoops.
Alrighty, so now we have, each lung is divided into 1 or 2 or more lobes. The lobes are still connected, so when we look at the sheet pluck on Tuesday, you can examine that and see that they're still connected quite deeply. On the right side, we have 3 lobes. Remember in the lung, we had 3 valves on our right AV valve, so it probably has to do with the shifting of the heart to the left side. But we have a horizontal fissure and an oblique fissure. Dotted line means it's on the back surface. All right. So the horizontal fissure is found only in the right lung. We don't use the word transverse, we call it horizontal. So in this whole area here is going to be the superior lobe, up to the apex and around to the back a little bit. This is the middle lobe. So the horizontal fissure separates superior and middle lobes. And then this is the inferior lobe. And it actually goes all the way around to the back. Okay, so looking at this model, here would be the horizontal fissure, right here. And here's the superior lobe and the middle lobe. Here is the oblique fissure going around to the back. So this part of the lung on the right side is the superior lobe. All of the rest of this is inferior. So when if you're sick and you're lying on your back, fluid, if you have pneumonia, it's going to drain into primarily your inferior lobe. All right, so if the doctor is listening to your breathing with the stethoscope, and he or she is on your back, basically all the way up into the lower, just above the inferior angle of your scapula, is all going to be inferior lobe. And if you place your hand on someone's scapula, then you're starting feeling the first upper portion of the superior lobe. All right, so the inferior lobe is shown primarily, predominantly, most of its volume is, or surface area is seen on the posterior aspect. So this fissure that separates middle from inferior or superior from inferior is known as the oblique fissure. On the left lung, like the bicuspid valve, we only have 2 lobes. So we have a single fissure known as the oblique fissure. This would be the superior lobe and inferior lobe. Now both lungs have an impression called the cardiac notch because the lung is, and the heart is mostly on the left side. The cardiac notch on the left side is more prominent. And as such, it leaves a narrow portion to the superior lobe, that somebody thought looked like a tongue, known as the lingula.
Does the oblique go all the way up?
It goes all the way up and wraps around to the back again, like it does on the right side. All right, let's look at the mediastinal surface. You'll notice that the left lung has an arch-like depression. What creates that? The aorta. So we have the arch of the aorta, the ascending aorta, arch of the aorta, and thoracic aorta. The right lung also has an arch-like depression. What do you think causes that? What would this vessel be right here? Good. Superior vena cava. What veins drain into the superior vena cava? It's formed by the union of the 2 brachiocephalic veins. They're coming in laterally from the right side, draining the right posterior chest wall. We have the ascites. And that comes up along the vertebral body. So that's what this depression is right here, arching over and draining into the superior vena cava. It's that impression created by the ascites. Now, if I just showed you 2 halves of the brain like this, the lung like this, you should be easily able to distinguish and identify right from left, because the right's going to have 2 fissures and 3 lobes, and the left is going to have 1 fissure and 2 lobes. All right? But you should also be able to identify it by the pattern of the structures in the hilus, even if you didn't see any part of the lobes. So we have 3 major structures associated with the hilus. We're leaving out the bronchial arteries and veins. Okay? So the airway on the right side is the bronchus. It may or may not have already divided into the 2 or 3. We'll just draw 1. Okay, so that's the bronchus. And in the right lung, the bronchus is superior. Okay? And posterior. And then we have the pulmonary artery anterior to it. Remember, the pulmonary artery is deoxygenated blood. And then the pulmonary veins would lie inferior. So this is the pattern of the right hilus. The key difference in the pattern for the left hilus is that the pulmonary artery arches over the bronchus. And so the pulmonary artery becomes superior, and the bronchus becomes inferior. Okay? And then we still have our pulmonary veins. So the key difference here is the relationship between the pulmonary artery and the bronchus. So let me just turn the lights down for a sec. So here's the bronchus, more posterior, and the pulmonary artery in front. All right. Here the pulmonary bronchus is inferior to the pulmonary artery. So even if you don't see any lobes of the lung, you can define it by that component. All right, then where I want to end up now, we'll talk about muscles that you learned last semester, or in 4:30, respiratory muscles on Tuesday when we talked about pulmonary ventilation. But the last thing I want to leave us with is the pleura. All righty? So attached to the surface, we have visceral pleura. It's going to be attached to the surface of the lung. The simple squamous epithelium. And then when it reaches the hilus, it reflects back on itself and now attaches laterally to the intercostal muscles. It goes down about 3 to 5 inches inferiorly. So that's great. It has its greatest amount of room inferior to the lungs. So when you breathe, the lungs expand to a greater degree inferiorly than anywhere else. So this pleural cavity here is also known as the pleural recess. Now remember I said I was going to talk about surface tension one more time, hydrogen bonds. So this is the serous membrane. Simple squamous epithelium of the pleura is secreting a watery fluid that fills this space. So between the parietal pleura and the visceral pleura, we have a thin film of fluid attaching the two membranes via surface tension, hydrogen bonds. This helps to maintain a slight pressure, keeping the lungs expanded a small degree. Because of the elastic fibers in the lung tissue, the tendency of the lungs is to recoil and collapse. All right? It makes it easier to expand the lungs and to breathe in, to have them maintain in a slightly expanded form. And that's created by the surface tension of the parietal pleura attaching via hydrogen bonds to the visceral pleura. So if we break that surface tension by adding air into the pleural cavity, we not only create a greater space and compress the lungs that way, but we break that natural pull to keep the lungs expanded. And so the lungs start to collapse. Of course, the greater amount of air that's in there, the greater the degree of collapsed lung you get. You can have fluid in there. That also will cause a collapsed lung because it's taking up increased volume. Okay? But at the initial component, air is going to cause that to happen more quickly as it breaks those hydrogen bonds. So for a given volume of air, you're going to have a greater collapsed lung than for the same volume of fluid because you've lost that surface tension component that helps to keep the lungs expanded. All right? Okay, we'll stop there. On Tuesday next week, which is the last week before spring break, on Tuesday next week, we'll talk about the movement of air into and out of the lungs and what happens if we introduce a pneumothorax. Talk about the case of a young British woman who went to Singapore and fell in love, didn't break her heart but broke her ribs, and nearly died on a jet trip back to England. Ended up getting a chest tube with the help of a clothes hanger and a bottle of water. So, true story. I saw it on the news back in 1999 or so, and I've seen a written description, but I haven't been able to find a news broadcast of it since. She went back and married the guy that caused the crash, not the doctor that saved her life. All right, so we're done with lecture. Let me go ahead and pass out your exams now, and then you can our lab quiz on Tuesday. We'll cover the structures listed in your anatomy lab packet as far as the parts of the pharynx and the tonsils, which we already covered, laryngeal muscles. I put some histology slides out there for the respiratory bronchioles, and most of them won't have a bronchus. I have one slide that does, if you're interested in it, bronchioles.
I have a question on the, when you're talking about the tracheotomy. Why is it, I've seen people, they say they've had a tracheotomy and they have like a big hole down here. Is that like a stoma or something they call it? But why do they go so far down here?
Down in this area?
Yes.
Depends on whether it's a permanent or a temporary one. If they're going to do an emergency one, they don't usually go that low. But it's faster than having to cut through the thyroid. That should only,
This is faster or is this one faster?
this down here would be faster.
Would this be safer to do too? Like if you weren't really sure if you could feel the correct spot?
Probably, I'd have to look it out to see, yeah, you're right, it's usually right here just
And
above the
that's
jugular knot area. I don't know if being closer to the, when I've treated patients, I had patients that had stomas, they were usually a little bit higher than that area, but I've seen the, I don't know if they use that more for a temporary one than for the permanent one, but I'd have to, do you have a question or comment?
Yeah, so when people go around with the little holes here, they like breathe through them, is that, why is that?
For some reason, maybe they had to have a removal of the part or most of the larynx due to tumors or some other conditions, sometimes polyps. I had a student whose son, as an infant, started developing polyps or growths on his vocal cords, and they didn't realize what was happening until he turned blue one day, and they had to rush him to the emergency room, and they removed the polyps, and they said they kept growing back, viral, like a wart or something. They said he may get over it as he got older, but he got really traumatized, if you will. I mean, he'd see anybody in a white coat, and he'd been scared to death. So the mom would call ahead of time and say they were bringing him in, and they'd take off there. But it's like, oh, you'd recognize the building and still know what was going to happen. They would be able to detect that it was getting time to remove the polyps because he'd become tired more easily, and he'd stop being so active and was more lethargic, and they knew that he wasn't getting enough oxygen, and it was time to take him back in for surgery.
You always see like those anti-smoking cigarette
Oh.
ads. They're smoking to that. It's like, why?
That's cancer of the larynx, or trachea stuff. Yeah, they'll put the inhales in there.
And I wasn't really close to her, so I didn't see her a lot, so
Yeah.
she did not stop smoking.
Yeah, I remember when I was working, it wasn't Saturday that it happened then, so I don't remember the hospital, but I was working as an RN, and I was walking through the lobby, and I overheard this woman say, she was, smoking in the smoking area, and she said, yeah, she said, my husband died of emphysema, but he was 80 years old, and I don't see the need for me to quit smoking. And I was like, but did you see how he died? I mean, it's not, dying of a lack of oxygen is not, to me, that would have been enough, to have had a loved one die without enough oxygen, but yeah, it was, well, there's plenty of people that live to old age and smoke, so you can always find, well, I've got it in my genes kind of a thing, it must have helped them live longer, but emphysema is, any COPD is not a very pleasant way to go.
Yeah.
Okay, let me pass the labs out first, and then you guys can take a break and do lab.
Oh, right to me.
Nice track.
Well, Sabrina,
Taking over,
and
but you can
Ginny.
still do this.
But like without a cigarette. Yeah. Sarah? Oh, here we go.
Like, I want to try it.
Kind of like
It is.
it's kind
Like a reflex.
Blood types. I use the non-glutenated blood instead of the glutenated blood to figure out if it's
My dad went
I know how my brother is.
Me too. His older brother's always
Madeline?
my dad's stuff.
Right here.
And he's still over
That's why it's so tough.
Okay, on the lab exam, these are recorded, but I forgot that I threw out question number 7. Number 7 was one on blood coagulation, and I asked the decreased PTT time, and I changed it from the morning one, which said increased. So the question was increased bleeding time, increased PTT, and then I changed yours to decrease bleeding time, but I left it at increased PTT. I was like, oh, well, that's kind of going both directions. So I threw it out, but there were, I didn't include that when I converted it to the extra credit components that the morning class had. So each of you gets an extra point, percentage point, okay? So I'll just go into the grade sheet and change that. But if you got a 75, I'll change it to a 76, okay? So there were 103 questions, and then there were 10 extra credit. That was a lot of extra credit, so what I did was I took the extra credit and made each one worth half, and so there were 8 points, there were still 8 points of extra credit, okay? So there were 108 points available, and then I just made your score as your percentage. Does that make sense? So you had 8 points of 8% of extra credit, I figured was about what I normally do anyway. So that's why you'll see, I'll go through some of the numbers on there. So if whatever you got, I will add 1 percentile point to that. There's no division that needs to happen to the total number of points. Yes?
on the lab.
I'll have to look at which one that is.
Everybody up here.
Blurry picture.
Yeah, we were all, it's blurry.
I did too. I think everybody did.
Yes, I felt. I had neutrophil.
We're in a neutrophil. And in addition to that, remember you get 2 points for being here today and looking at your exam. So
Okay.
that's on D2L. That's in my Excel spreadsheet. Okay, so I don't change the score on your test because I want to know what your actual score was. Amy? Eric?
That was one of those questions. There's a couple.
I think that was just credit because we didn't know if we were looking at it. Top or bottom. Oh my gosh, I had
Natalia? Okay.
Sure, you just show them there.
Okay, so if you look on, there are a couple of confusing things about your test if you're trying to interpret it. So the okays meant my Scantron key was wrong, and I went back and gave you credit if you had the correct answer marked wrong. So that's what the okays mean. The half points are where I went back and gave half credit if the answer was A and B, and you had A or B, or the answer was all the above, and you had D, which was A and B or A and C. Okay, so that's what the half points were. And then now on the fill-ins, on the page where the blood typing was, each of the answers, if you chose the correct answer, was worth a quarter point. If you chose correctly not to circle it, was also worth a quarter point. All right, so 4 correct answers are 1 point. So each of the blood typing is 2 points. So what I did, rather than try to figure out for each one, is I added up all the correct answers you got and divided by 4. Okay? So over here was the number of correct little boxes you got, added together, divided by 4. So if you got 13 right, you got 3 1/4 points. Okay? If you got 15 right, you got 3 3/4 of a point. So that math is done over here on the side. Okay? And then everything else is worth a point. At the bottom of the page, this is just for the fill-ins. The matching up here was done in your Scantron. So don't add those in, you'll be off. That was included in your Scantron. The points at the bottom of the page just start with part 1. All right? Then if you look on the back, each of these fill-ins up here are worth a point. And then the extra credit ones were half a point, so I took each of those, and if you got 8 right, you got 4. Okay? If you got 8 1/2 right, you got 4 1/4. So that's what this is meaning down here.
Can you repeat that?
Okay, so the extra credit was worth a half point each, but I gave half credit. So if you put CD4 and the answer was CD8, I gave you half credit for the CD part of it. Or if you put MHC, if you put interleukin 1, it's supposed to be interleukin 2, I gave you half credit for interleukin. Half a point. Yeah, okay. So when I cut it in half, that made it a quarter, okay? So if you got 9 of them right, you got 4 1/2 points. If you got 8 1/2 right, you got 4 1/4 points. So that's kind of how the math of that is done there. And this number at the very bottom here should equal the number at the top and on your Scantron. Okay, so the 8 points, if you want to know, this wasn't question per question, really, it's just all the points. But up through here, for all of these questions down to here, these last 3, that was 100 points to here. All right? So then your extra credit was these 3 plus the 5 from the extra credit. Now it doesn't matter whether you got those right or not, it's total points. So essentially I add up all your points, and that's your number out of 100. Okay? So yours actually adds up to 99 because I threw out question 7. So that's why I'm going to go back in and add a point to everybody. Okay? If you got question number 7 right, then you interpret it the way I interpret it, then you get to keep that right point. I think there was 1 person. Okay? So I'll give everybody an extra point. Okay? Not an extra.